So what is an electrodiagnostic medicine consultation? These are the questions that I'm going to try to help you answer. Who is qualified to be an electrodiagnostic practitioner? And how can you know that the studies you order are of the highest quality? Well, one thing is to be clear that the lab is accredited, that the people that are doing the tests are fellowship trained and are certified by the American Board of Electrodiagnostic Medicine. You have to know your indications for an electrodiagnostic medicine consultation and be aware of the limitations of the testing, as I've already described. So I'm going to answer what is an EMG, how is it done, what can it diagnose, and what should I expect from the EMG report. So a good electrodiagnostic medicine consultation needs to be part of some history and physical examination. Okay, so you can identify a good EMG report if it includes some history and physical examination. Okay, it usually should be a focused neuromuscular evaluation. Okay, so that the data that you assemble, okay, has to make total clinical sense. Okay, the two things have to go together. You can't find findings on nerve conduction studies that have absolutely make no sense with regards to the physical examination, for example. Okay. So the EMG part of the test refers to the needle part, where we put a needle in the muscle. All right, and we're looking for signs of membrane instability. If I put a needle EMG into the muscle, the resting activity should be flat. Okay. If there are spontaneous discharges, spontaneous depolarizations of individual muscle fibers, they are what we call fibrillations or positive sharp waves, and we see those when there has been denervation. Okay, when the axon, there has been some motor axon loss. Okay, we do not see those when there's just been block, when there's been what we call conduction block or neuropraxia or pure demyelination. So there has to be some nerve disconnection between the axon and the muscle fiber for these fibrillations and positive sharp waves to appear. Now, the people, there's so many people doing EMG and nerve conduction studies. A majority of them are not qualified to do the test. To do the test properly, you need a year fellowship doing EMG and nerve conduction studies, which includes training in neurophysiology. The nerve conduction study part of the test can tend to be very tedious. To do it properly, it has a lot of technical problems. Some of the technical problems include making sure that the limb is warm enough. If the limb is cold, okay, it will artificially reduce the nerve conduction velocities and prolong the distal terminal or distal motor latencies. There are also issues with if there is any kind of lotion or oil on the extremities, that will interfere with the ability of the electrodes to stick and record properly. Okay. These are just technical issues. The conduction studies get harder to do as patients get older. So you really need to do a year of EMG. So the type of doctors that do the test are neurologists and physiatrists. The nerve conduction study part of the test is often done by a technologist, but one way you can identify when the test is done properly or not is when the doctor rechecks something. So it is my policy, if something's abnormal, especially if it's an isolated finding, I will recheck it. Okay? So you want to know that the person you're referring the patient to has done a fellowship in clinical electrophysiology and EMG and nerve conduction studies. So what are the indications for an electrodiagnostic medicine consultation? So basically, there are any disease or disorder that involves the motor neuron, the sensory neuron, the nerve root, plexus, peripheral nerve, neuromuscular junction or muscle. So that means patients with pain, numbness, tingling, cramping, spasms, weakness, gait difficulty, and fatigable weakness. In the critical care setting, these tests are sometimes ordered too, and they are ordered when there is generalized weakness, inability to wean off a ventilator, for example, acute or unexplained onset of respiratory failure, which may be neurogenic in origin, or diaphragmatic weakness. So we may be asked to do them in those patients for critical illness, polyneuropathy, or myopathy. So the EMG and nerve conduction studies are very useful in distinguishing radiculopathy from plexopathy or neuropathy, right? Because in radiculopathy, the sensory nerve conduction studies will be normal, and radiculopathy and plexopathy, they're going to be reduced, okay? They also clarify the type of neuropathy, meaning is it a demyelinating disorder, affecting large myelinated fibers, or is it an axonal disorder, okay? Now, axonal peripheral neuropathies are much, much more common than demyelinating peripheral neuropathies, okay? So the axonal peripheral neuropathies, the commonest causes would be diabetes, impaired glucose tolerance, and alcohol abuse, right? The demyelinating polyneuropathies are Guillain-Barré or chronic inflammatory demyelinating polyneuropathy. So the axonal disorders are much, much more common. They also identify a potential source of pain and localize the site of the peripheral nervous system lesion. These tests will be completely normal in patients with symptoms and signs due to a central nervous system disorder. Okay? These tests purely examine the electrical part of the peripheral nervous system only. You can just imagine that it's a wire. They can also predict prognosis in terms of making an objective measurement of the degree of denervation, and they also tell us whether the re-innervation process has started or not. So the components of an EMG are the nerve conduction studies that I was talking about before, and the EMG, the needle part. The two tests go together. One way you can identify bad studies are internists sometimes refer patients to themselves, and they just do nerve conduction studies alone without the needle EMG, okay, which is not allowed, for example, by Medicare. The two tests have to be done together, okay? So here is what nerve conduction studies here look like. Here we're looking at the median nerve, okay? You can see this is the stimulation at the wrist, this is the stimulation at the elbow, okay? And the conduction velocity measures the subtraction of this latency from this latency, and then dividing that into the distance in centimeters between the wrist and elbow stimulation points, okay? Here is the sensory nerve conduction study, okay? And we can record from different digits, okay, to try and increase the specificity of the study. So the standard one we record from is second finger on the palmar side. Then we can also record from the third, fourth, or the thumb. And you can see the little peaked sensory nerve action potential here. Now we have normals for the size of the potential, okay? And we can stimulate in sensory nerve conduction studies. We can do them one of two ways, either of two ways. We can stimulate the nerve orthodromically, meaning we can stimulate the sensory digital nerves in the fingertip. Okay, so you can just put the stimulator on here, or we can wrap ring electrodes and connect it to the stimulator, and we can record from the median nerve here. Okay, or stimulate this fingertip and record from the ulnar nerve here. Okay, and they're called orthodromic sensory conduction studies. Ortho meaning physiologically that's how sensory nerves are stimulated. Okay, but remember, this is just a wire. We can we can just stimulate. We can go the other way, antidromically. Stimulate the median nerve here and record from the digital nerves. Okay, the antidromic sensory conduction studies, the responses are larger, but it's often just easier to do the antidromic conduction studies because you don't have to wrap these ring electrodes around. It's just quicker. Now the needle EMG part, here we should have a flat line at rest. But here you can see this little spontaneous depolarization here. This is a fibrillation potential, okay? And it has a specific sound. It sounds like a rain on a tin roof. It's like a tick, little sharp sound like that. So, so these are fibrillation potentials here. And what these mean are that the muscle, okay, has been denervated, okay? And they take a while to develop. It depends on how long. If it's, for example, if the nerve injury is at the root level, at let's say L5, and you're recording from a muscle on the top of the foot, that could take 3 weeks for the dying back process to cause these fibrillations and positive sharp waves to appear. Okay, so it's as long as up to a month, but as short as a week. Okay, so that's why you have to be careful about ordering EMG nerve conduction studies within the first week after peripheral nerve injury. You're not going to get, Wallerian degeneration will not have been complete by then, and you'll be stimulating the nerve below the injury, and things will appear better than they really are because the nerve has not died back fully. Also, these fibrillations and positive sharp waves will not have had time to develop yet. These fibrillations and positive sharp waves are obviously not a good sign, right? The more of them there are, the worse the degree of denervation. And the only way that things can get better when you have denervation, okay, is through reinnervation. Now, if it was purely neuropraxia, where you have paranodal demyelination and just nerve compression, well, obviously decompressing the nerve will resolve the conduction block and the action potentials will all go through. The weakness and tingling will stop. It's just no different than just uncrossing your legs, okay? So here's the the EMG machine. You need an adjustable bed. The responses that we record are the compound motor action potential I talked about, the sensory nerve action potential. There are also special what we call late responses, where we extend the time base and we record what are known as F waves and H reflexes. These are called late responses. I'll describe these later. So here's how we do the test. We stimulate the median nerve here at the wrist, and we record from the abductor pollicis brevis. This is the active electrode, and this is the reference. So we supramaximally stimulate all the nerves here so that the response can't get any bigger than this. And then we do the same thing up at the antecubital fossa. Okay? And this here represents the difference in voltage between the active and reference point. Okay? Now here's a sensory nerve conduction study orthodromically stimulating the is he listening? I'm sorry, what? Are you listening or you're not listening? I'm from audio visual. Oh, I thought you're a fellow. Oh, okay. So this is stimulating the digital nerve here and recording from the median nerve here. Okay? So this is orthodromic. We could do it the other way. We can stimulate the nerve here and record from these electrodes. That's antidromic. And here is this sensory nerve action potential. Okay, we have normals for the amplitude of the response, and the velocity should be over 50. Same for sensory and motors, 50. Okay, 50 for the upper extremity. Sensory, right? It doesn't matter. Oh. 50 nerves. It doesn't matter whether they're sensory or motor. Nerves in the upper extremity should conduct at 50 meters per second. What kind of nerves are we talking about now? Large myelinated. Correct. Good. Okay. How slow can the small unmyelinated fibers conduct? How slow? A lot slower. Okay, a lot slower. Yeah, it's like 5 to 10 meters per second, like 10 times slower. Okay. So usually they're conducting so slowly that they have a negligible contribution to these action potential responses. Okay. Compound action potential responses. So we need the motor nerve conductions, we need the sensory nerve conductions, and we'll need these late responses that I'm going to talk about now. Now, in the nerve conduction studies, the things that we want to know are the latency, okay, motor and sensory, which is I've explained, the amplitude of the response, okay, which refers to most people measure the negative peak amplitude. So here's the negative onset of the things above the baseline are negative, below are positive. So This is the latency, and the negative peak amplitude represents the onset of the deviation from the baseline to the negative peak. Okay? Some people measure the positive peak, which is the difference between the peak here and the positive trough. Okay? But most labs will record the amplitude means the size of the response here. Okay? So that's the amplitude. So we have norms for that. And the conduction velocity. Okay. Now the F wave, I want to get here. Okay. So if in the standard motor nerve conduction study, you can see here that the sweep speed is 5 milliseconds per division. Okay, or along here, right? Now, if I were to change the sweep speed by 10, okay, make this 10 times longer, okay, that will push these responses way over to the left, right? Okay. Well, when we do that, and we stimulate the nerve supramaximally, and we're recording from the muscle, we will see, here is that response down there at the wrist, right? See here? That's called the M response, which is what the previous slide showed. Well, when we do that, we start to see what are called late responses, which are called F waves, okay? And you can see that they vary in shape, okay? And the latency varies, okay? This one's here, this one's over here, so that we can measure a minimum latency and a maximum latency, okay? The minimum F wave latency is the absolute number we use to determine whether it's normal or not. Now, what is this? Well, when we stimulate the median nerve at the wrist supramaximally, okay, we cause the action potential, remember, to go down to the muscle, make the muscle twitch, right? But you should also know that this is just a wire. It's not smart. It's just like a copper wire. So that the action potentials go both ways, okay? So that the depolarization wave goes proximally and distally, okay? Now, the depolarization wave that goes proximally will travel up the axons that are connected to the neuromuscular junctions in this muscle, and they're going to go all the way up to the what? Spinal cord, yeah. And what cell in the spinal cord? So they're going to go up to the anterior horn cell, right? Because this is a motor. We're recording from a muscle. Okay, this is a motor nerve conduction study. So they're going to go all the way up into the anterior horn cell, okay? And what's going to happen there is about 98% of them are going to die out, okay, at the axon hillock. They're not going to come all the way back down again. But a small number, 2% or so, are going to travel. They're going to literally electrically bounce off the anterior horn cell and come all the way back down again, okay? So these disorders are useful, therefore, they're going to disappear, okay, in disorders that affect the nerve root, okay, cause slowing or loss of fibers in the nerve root, okay? So they're useful for diagnosing more proximal nerve disorders, okay? So the only problem is when we're recording from this muscle here, I don't know if you know what myotome this is, so this would only be good for diagnosing T1 radiculopathies, which are extremely rare. And this one here, recording from the ulnar nerves in the hand, these are C8 myotome. So we don't really have good F waves to diagnose C6 or C7 radiculopathies, just C8 and T1. But in the leg, when we record from the extensor digitorum brevis muscle on the top of the foot, that's a real L5 muscle. So you want to know where the F waves prolonged, especially if they were prolonged side to side. There was a difference between the symptomatic and asymptomatic side. Okay? It's also important to do nerve conduction studies bilaterally and compare the asymptomatic with the symptomatic sides. Okay? These F waves, though, will also be prolonged if there's any slowing anywhere along the whole pathway. So, for example, in a carpal tunnel, they'll prolong the F waves too because there's an area of slowing. Okay? The thing goes all the way up, down, and if it's slow here, that will prolong the F wave too. Okay? So they're going to be prolonged in any nerve disorder. So neuromuscular junction testing, it's not so important for you because it doesn't really involve pain. But what we do is we stimulate the nerve at 3 Hertz supramaximally, and there should be no fatigue at the neuromuscular junction. Okay, the responses should be the same. If there's something wrong with the safety factor, okay, meaning there aren't enough acetylcholine receptors, there aren't enough acetylcholine vesicles, okay, or the presynaptic calcium channels are blocked by antibodies. So anything that interferes with the safety factor. The safety factor is a term that's used for the fact that you have, in a physiological situation, normal physiological situation, you should know that we have 10 times as many acetylcholine receptors as are needed to generate a supramaximal action potential in the muscle fiber. Okay, we have at least 10 times as more acetylcholine vesicles in the presynaptic junction than is necessary. Okay, the same with the calcium channels, etc. In other words, the system is so built in to generate action potentials from nerve to muscle that it doesn't really matter what happens. The responses will get through and the chemical transmission will occur. So if there's something wrong, okay, the safety factor is disturbed, and the more we use the system, the more the compound muscle action potentials drop. So this is something called a decrement. Okay, it needs to be more than 10%. And that's diagnostic there of a neuromuscular transmission disorder. Now with the needle EMG, a needle electrode is inserted into the muscle. Okay, it's sterile, disposable, and what we're looking for are those fibrillations and positive sharp waves indicating, excuse me, indicating denervation. Okay, and if we know the neuroanatomy, I mean, it's all very well sticking the needle in and seeing the fibs and positives, but you need to know that, you know, I just stuck it in the biceps. Well, that's, you know, that's supplied by the C5 anterior horn cell mainly, you know, and then it's upper trunk brachial plexus, and then it's the lateral cord musculocutaneous nerve. So then you're thinking, oh, well, it could be just a musculocutaneous neuropathy, or it could be so what you would do is, oh, but I think it's a C5 radiculopathy. Well, then you go, oh, well, then there should be something in the deltoid, and there should be something in the infraspinatus. There should be something in the C5 paraspinal muscle. Okay, so this is the way you think to make the diagnosis. So we have to do a combination of muscles. The muscle is studied at rest, and then we ask the patient to move the muscle voluntarily. And what happens when we move the muscle voluntarily is the needle detects those equivalent of the motor units that I was talking about when recording from the surface. When we record them with a needle, the motor units are much sharper, and they should have less than 4 phases across the baseline. If they have more than 4 phases across the baseline, they're what are called polyphasic. And motor units become polyphasic with reinnervation. They become enlarged, they become prolonged, okay? And that reinnervation process takes weeks to months, right? So the appearance of prolonged and polyphasic motor units indicates that the reinnervation process has started, okay? Now, so here's an example here of an isolated fibrillation potential here, okay? This is the needle in the APB. So this is a little bit of denervation. So we could say, well, there must be something wrong, right, with either anything from the T1 anterior horn cell, T1 nerve root. This muscle is mainly supplied by T1 nerve root, lower trunk of the brachial plexus, medial cord of the brachial plexus, the median nerve, right? So if you know your anatomy, you walk your whole way down. But let's say on your nerve conduction studies, your distal motor response latency was very prolonged, and the forearm conduction velocity was normal, and the right median sensory conduction studies showed slowing, right? Well, then you could say, oh, well, this is just a little bit of denervation complicating the carpal tunnel syndrome, okay? So the things we're looking for on needle EMG are the insertional activity. We're looking for those spontaneous fibrillations and positive sharp waves. Then when we activate them, when the patient recruits the muscle, we want to know, are the motor units normal, meaning they're not abnormally prolonged, they're not polyphasic, they're not enlarged. And this involves a fellowship training, whether you decide whether that you have to be trained to see that or not. And then there's the motor unit recruitment. Normally the motor units should recruit in a sequential fashion. So when a patient actively, minimally recruits a muscle, it'll make a sound like dot, 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 meaning that single motor unit will fire at that frequency. Now, when the patient tries to move the muscle more, that motor unit will, at some point, will fire at the maximal frequency it is programmed to fire at. Then, more strength will come from new motor units, new anterior horn cells discharging. Okay, so they'll go da 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 da, and then you'll see more and more new motor units coming in. This sequence of motor unit recruitment, okay, is orderly, and if it's disturbed, what will happen is you will get increased recruitment of the earlier recruited motor units. So it will sound something like, in other words, the motor units will be firing too fast because the system is hardwired such that that is the only way to generate more strength, okay, is by making the motor units, those that are working, fire faster, okay? So that's called reduced or neurogenic recruitment. Okay, so the fibrillations and positive sharp waves that occur with denervation, okay, are actually a result of denervation hypersensitivity. So when the muscle fibers become denervated, the response that their response to that is to generate more acetylcholine receptors, okay, as a result of denervation supersensitivity. This happens anywhere in the nervous system. When you denervate something on the sensory level or anywhere in the autonomic nervous system, a smooth muscle fiber will do this anywhere. So its natural response is to increase the number of receptors to try and generate an action potential. So what that does is it makes the muscle fiber prone to membrane instability because of an excessive number of acetylcholine receptors. Okay, and that will be detected as a single muscle fiber discharge called a fibrillation or a positive sharp wave. So these are a positive sharp wave, meaning it goes down and comes up. The fibrillation potential looks like this. They're both the same. They both mean the same thing. They both mean membrane instability, usually due to denervation, although they can also occur due to a muscle disease. Okay. Then there are disorders in the where you have involuntary motor unit recruitment. They can be complex repetitive discharges. These occur in usually chronic nerve disorders or nerve root disorders. They take months to happen. Myokymia happens in nerve compression disorders, and myotonia in patients with myotonic dystrophy. These are involuntary motor unit recruitment disorders or cramp-like disorders. So the grading of the spontaneous activity, and the report will include this, is we just basically, if they're isolated fibrillations, they're 1+. If they're positive sharp waves, you can see here they're getting more and more common. 1+, 2+, 3+. 4+ is just the screen is full of these. They're continuous. They don't stop. 3+, there's some intervening flat areas. 2+, they're intermittent. And 1+, they're very isolated. So the motor unit configuration, the muscle is volitionally activated at different force levels. Single motor units are assessed. So you're moving the needle very delicately and you're trying to focus on the motor unit to let you hear it come in very sharp and clicking. And you're looking at the size, but mainly the duration and whether there are no more than 4 phases crossing the baseline. We want normal serial motor unit recruitment. We don't want to see reduced recruitment or high frequency motor unit recruitment. If we see high frequency motor unit recruitment, that means that there are not enough motor axons working, either because there's been a loss of anterior horn cells, or the motor axons are dying, or they were blocked, for example, at a carpal tunnel compression. Okay, and if we see, if we see a motor unit here that has, 1, 2, 3, 4, 5, 6 phases across the baseline here, this is a polyphasic motor unit. It's also abnormally prolonged. Okay, its onset is here. it doesn't finish till here. That's a 30 millisecond per motor unit. They should be 10 to 12 motor. They get longer as you get older. There are published norms for different ages. So here, so what you'll see here, this is in the left vastus lateralis, right? So we can say here that a reinnervation process has occurred, okay, such that muscle fibers that were denervated have now been reinnervated by new axon sprouts, okay, that are connected to an anterior horn cell, okay? And so we can say that something must have happened, okay, somewhere from the L4 anterior horn cell down the ventral ramus of L4 into the femoral, through the lumbosacral plexus and into the femoral nerve, okay? So you might say then, well, how are we going to discriminate between an L4 radiculopathy, which is what I think this is, versus a problem, postganglionic problem in the plexus or the femoral nerve? You know, where did this nerve injury that led to this reinnervation occur? Well, the way to distinguish the two things is to measure a sensory nerve conduction study that's connected to this system, which will be the femoral nerve. So what is the sensory nerve that's connected to the femoral nerve? No. But you're good, you're thinking well. It's the saphenous nerve.
Oh, yeah.
So you would do a saphenous sensory conduction study, and you would compare the two sides, right? And if the saphenous sensory response was absent on the side where you see this on needle EMG, and it was present on the other side, well, then you would go, wow, this is a postganglia, this is a plexus or femoral nerve. And then how would you discriminate lumbar plexopathy from a femoral neuropathy? Well, then you would stick the needle in an obturator innervated muscle, because the obturator nerve is connected to the lumbar plexus too. And if you didn't see these motor units in the obturator, like the hippoductor muscles, right? Then you could say, wow, so there has been femoral neuropathy, which is reinnervating. Okay. Now, the more this process of reinnervation occurs, those fibrillations and positive sharp waves will start to disappear. Okay, they'll start to go away with reinnervation. If the reinnervation process is complete and perfect, okay, what you'll see is normal recruitment. You won't hear these units going, they'll be go, right? But the motor units will always remain this way as a result of the reinnervation, okay? If the reinnervation process is incomplete, you'll see some residual fibrillations and positive sharp waves and persistently reduced recruitment, okay, which manifests itself clinically as weakness. Okay, you don't need this. So the so the normal findings on a nerve conduction study merely mean that the larger myelinated nerve fibers are working, and you cannot discriminate. So if you have someone with you suspect a painful small fiber polyneuropathy, then the routine nerve conduction studies are going to be normal. Okay. There are some tests you can do to try to isolate small nerve fiber functions. You can test the nerves as distally as possible. Okay. So instead of doing a sural sensory conduction study, which means recording from here behind the lateral malleolus and stimulating the sural nerve here, what you can do is you can put the pickup electrode behind the medial malleolus and stimulate in the sole of the foot, stimulate the plantar nerves, because the plantar nerves are going to be smaller, okay, and less heavily myelinated than the sural nerves. Okay, so in a selective small fiber polyneuropathy, the plantar sensory responses may be reduced or slowed. Okay, you can also do a sympathetic sensory skin response, right, which measures pseudomotor function. So sweat glands are innervated by unmyelinated fibers, right? So there are some limitations with normal studies and patients that have symptoms suggestive of small fiber nerve dysfunction. Which means patients that have, burning neuropathic pain without any paresthesia or weakness, and a normal neurological examination, for example, in terms of normal reflexes, because reflexes and strength and your tuning fork and those things are measuring large fibers, right? So in patients with isolated small fiber polyneuropathy, the only thing you might see is reduced pin sensation. But even when you're testing with a pin, you are aware that that's what you're measuring, what is called fast pain or faster pain. You know, you're using a pin, okay? And even in patients with isolated small fiber polyneuropathy, the pin sensation, they may not report restocking, distribution, reduction, sensory loss. So radiculopathy, it's useful for diagnosing radiculopathy and discriminating radiculopathy from plexopathy based on the sensory conduction studies. There are some limitations, unfortunately, as people get older and sicker. They have things like, so in the scenario I was going over with you, discriminating femoral neuropathy from L4 radiculopathy from lumbar plexopathy, you would use the Saphenous conduction study. But, you know, that would all get screwed up if the patient was, you know, 78 and had diabetes for 25 years. That patient's not going to have Saphenous sensory responses on either side, okay? So, neuropathy and myopathy. So, and widespread denervation occurs in motor neuron disease and disorders of neuromuscular transmission. We can tell the difference between acute injuries, okay, are where the compound muscle action potentials and the sensory nerve action potential amplitudes are going to fall, okay? We want to diagnose acute injuries more than a week old, okay? If we do the study within a week, we're going to be stimulating the nerve below the injury before Wallerian degeneration has occurred, and the conduction, and it may look like the nerve distal to the injury is alive and intact. So you may diagnose conduction block across the nerve injury when there isn't really conduction block. It's just that the nerve hasn't died back yet. So we want to make sure that the timing is right. So when in acute nerve injuries, we have small responses without those fibrillations and positive sharp waves and reduced recruitment of motor units, right? In subacute nerve injuries, those fibrillations and positive sharp waves start to kick in. These are in denervating nerve injuries with axon loss. In demyelinating nerve injuries, we're going to see conduction block across the area of block. We're going to see slowing of nerve conduction, and we're going to see very prolonged latencies. Okay, but we're not going to see those fibrillations and positive sharp waves. So, and then in a chronic disorder, we're going to see reinnervation start to kick in. Okay, we're going to see those big units, reduced recruitment of big polyphasic units, prolonged and enlarged. Also with or without fasciculations. Fasciculations are also occur as a result of reinnervation, and they develop weeks or months later. So a fasciculation is where you have you can see this clinically, but if you have a needle in the muscle, you'll have a spontaneous motor unit discharge, right? The thing will just go pop, like a popcorn, okay? So anatomic location, we can distinguish root, plexus, nerve, neuromuscular junction, and muscle. We can determine the distribution, okay? Is it a polyradiculopathy or a monoradiculopathy, okay? Is it affecting the trunks or cords of the plexi? Is it a mononeuropathy or a multiple mononeuropathy, meaning mononeuritis multiplex, or is it a distal symmetric disorder? Is it axonal or demyelinating? So we're going to be able to diagnose motor neuron disease, radiculopathy, plexopathy, muscle disease. Now, in the case of radiculopathy, if we had, for example, a compressive disorder, okay, on the, let's say, the C6 nerve root, that's the most common one, right? And let's say it wasn't causing any axon damage at all, right? You just had a, okay? Now, the sensory nerve conduction study for C6, right, would be off which digit in the hand? Which one is your C6? It's your thumb, right? Oh, yeah. Your thumb, right? So you would have to stimulate the thumb and measure from the radial nerve or the median nerve, right? That's a C6 sensory conduction study, right? So in a patient with a C6 radiculopathy, even if the nerve was cut there, right, totally severed, and they had no brachioradialis function or reflex or anything, that sensory conduction study would be what? Normal, right? Because in radiculopathy, that's a preganglionic disorder. But let's say, so, okay, and the C6 nerve root was cut, and then I stuck a needle in the brachioradialis, right? So if it occurred in the first week of the disorder, the patient, there may be no recruitment at all, right? But no fibs. But if we waited like 2 weeks, We're going to see a lot of fibs, right? Tons of fibrillations, positive sharp waves. Okay, maybe no or very reduced recruitment of normal motor units. But then if we wait, we do the study at 3 months, we're going to see reduced recruitment of enlarged, prolonged polyphasic motor units, maybe with some decline in fibrillations and positive sharp waves. So these tests are very good at diagnosing denervating radiculopathy, right? But not all radiculopathy is denervating. There could be just some compression on the C6 nerve root and no axon loss at all. So in that case, the sensory conduction study is no good. The needle EMG could be normal, right? The patient could be just tilting their head one way and get pain, and right? So there are some limitations. So in radiculopathy, the needle EMG, okay, diagnoses denervation, okay? So the things you should expect from the EMG report are a clinically and physiologically relevant interpretation and diagnosis. You need adjectives that describe the localization, the severity, and acuity of the process, whether there's reinnervation or not, whether there's continues to be denervation, and a prediction of recovery or prognosis, and an explanation of any technical problems. So for each abnormality on the nerve conduction study, there should be a rational, coherent explanation for it. Okay? It also might need to comment on whether the test needs to be repeated, and most importantly, if the procedure is accompanied by a clinical evaluation, which it should be, the electrophysiologist should be comfortable with giving you some clinical advice. Carpal tunnel release surgery should be considered. The median sensory responses are almost absent, meaning there's been severe sensory axon loss. There's some early fibrillations and positive sharp waves in the APB, meaning there's active denervation to this muscle, and we should release the nerve. So we talked about the side-to-side comparisons, the data, the EMG in terms of the degree of spontaneous fibrillations and positive sharp waves, whether the motor units show reinnervation or not, if the recruitment is reduced. So the report should say something like, you know, this is a good, there is electrophysiological evidence for a severe and acute left femoral mononeuropathy at the inguinal ligament. There is no evidence for radiculopathy. Okay, why would they say that? Well, because the hip adductor muscles, the adductor magnus, adductor longus, showed normal findings, right? Plexopathy, because the saphenous sensory conduction studies were normal, and the other muscles innervated by the lumbar plexus, the hip adductors, the iliopsoas, they were normal. The abnormalities were restricted to the femoral nerve distribution, in other words, just the quadriceps muscle. Okay? A follow-up study may help predict prognosis for recovery, meaning a follow-up study, because this is acute, the fibrillations and positive sharp waves weren't there yet. So a follow-up study in a few weeks will determine whether the femoral nerve just had neuropraxia. But if it was severely damaged, those fibrillations, positive sharp waves are going to appear. Okay. So EMG studies are a supplement, okay, to the history and physical examination. They can't replace them. Also, the nerve conduction studies are like a camera. They don't lie. You can't, if they're done properly, they are what they are, and they're compared side to side. So they always have to make sense. Okay, so when I see a finding that doesn't make sense, I just do it again. Okay? So a good key is you could ask your patient, did the doctor do any of the tests? Usually you could ask the patient, you know, who did the test? Oh, I went into this place and this woman, you know, she barely spoke English and she did these electrical shocks. The doctor came in and stuck needles in me and left in about 3 minutes. Okay? You know that's not a well done test. Okay, I think, well, we talked about neuropraxia. Okay, I didn't talk about that. Is the mildest or most transient disruption of nerve function. It's due to either ischemic, metabolic, or microstructural abnormalities. The axonal integrity is maintained. So it's a reversible failure of nerve conduction. Okay, it's a failure of saltatory conduction because of the area next to the node of Ranvier becomes exposed because the sausages of myelin get pushed apart, often due to compression. Okay, so that when the action potential arrives, it is very likely to just what? Depolarize the nerve underneath, right? And not spread, not leap to the next node of Ranvier, okay? Because what happens is when you spread the nodes like that further apart, the myelin further apart, you're making the node of Ranvier, you're exposing or extending the node of Ranvier into a paranodal area. It doesn't have as many sodium channels, and so the response won't leap, it won't jump. So what happens with that is the patient feels tingling because of a failure of sensory action potentials to get through, and weakness because of a failure of motor action potentials to get through. So it's usually most often compressive or ischemic, and it normalizes in hours to weeks. It's the equivalent of crossing your knees. In an axonotmesis, there's disruption of the axon and the myelin sheath with supporting connective tissue spared. That, remember I talked about the endoneurium and the perineurium and the epineurium? That's like the scaffolding through which the axons run, okay? So in axonotmesis, it could be minimal, incomplete, or full. Okay, if it's minimal, it'll be some fibrillations, positive sharp waves, may not affect recruitment at all. If it's incomplete, it's going to cause significantly reduced recruitment with large numbers of fibs and positive sharp waves. If it's complete, there's going to be continuous fibrillations and positive sharp waves, as long as enough time has been allowed for those to develop, which I went through, it's up to 3 weeks. And there'll be no recruitment at all, okay, absent recruitment, okay. It depends upon the severity and length of the nerve injured, okay. The recovery will occur via axonal sprouting and regeneration, and a growth rate is about 1 to 3 millimeters per day. And why the nerves grow? Because the endoneurial tubes of connective tissue are still there, okay, so that the nerve goes the right way. That doesn't mean mistakes don't happen. Mistakes do happen, right? So in that case, we have what is called synkinetic reinnervation or aberrant reinnervation, for example, in the facial nerve. Everyone that gets a Bell's palsy gets some synkinetic reinnervation, everybody. That's how you can identify an old Bell's palsy. You just ask the patient to blink, right? And the side of their mouth will twitch, will go, okay? That's a universal finding in patients that recover from Bell's palsy, for example. Okay. So the most common causes are crush and stretch, and the recovery will obviously take months because it's due to reinnervation and has to grow back. And then neuronotmesis or neurotmesis is a nerve transection, okay, disrupting the axons, myelin sheaths, and the supporting connective tissue. Okay, what's the only way that that can be can recovery occur? Surgery. Yes, correct. So, and when should that be done? Good. Yeah. So, because you need to juxtapose the transected ends and axonal growth. So if you don't do it acutely, Wallerian degeneration will occur and the distal axon will degenerate. It'll totally degenerate, and what will happen is you'll get the formation of what at the proximal nerve ending?